This is the second part of our series of lecture on adrenergic antagonists. We're going to switch gears and now move on to the beta blockers or beta-adrenergic antagonist.
By the end of this video, you should be able to discuss the beta-adrenergic antagonist in terms of its mechanism of action, pharmacological effects, and of course the clinical uses. To understand how beta blockers work, we need to talk about the different types of beta receptors, basically in terms of its distribution and function. To recap, beta-1 receptors are mainly located on the heart, and when activated would lead to increase in heart rate as well as increase in cardiac contractility and atrioventricular node conduction. Beta-1 receptors are also located on the juxtaglomerular cells in the kidney, and when activated it would lead to increased renin release, which would then indirectly affect or rather would cause an increase in blood pressure. Beta-2 receptors are mainly located in the lungs on the bronchial smooth muscle, and when activated would lead to bronchodilation. They are also located on the vascular smooth muscle and the arteries of skeletal muscle, and when activated it would lead to relaxation of blood vessels, or in other words vasodilation. Beta-2 receptors are also located on the smooth muscle in GI tract and uterus, and when activated they would lead to smooth muscle relaxation, which in the gastrointestinal tract will result in decreased motility, and in the uterus it can cause inhibition of labor. Lastly, beta-2 receptors can be found in the pancreas, and when activated it would lead to an increase in insulin secretion. Let's not forget about beta-3 receptors. Beta-3 receptors are mainly located in the adipose tissue, and when activated, they lead to increase in lipolysis or simply breakdown of stored fats. Just like alpha antagonists, beta blockers or beta antagonists can also be subdivided into selective and non-selective agents. However, unlike alpha antagonists, beta blockers or beta antagonists can also be grouped in generations. Basically, it is classified into the first generation, second generation, and third generation beta blockers. Beta blockers are competitive inhibitors at beta-adrenergic receptors, and they would counter the effects of catecholamines such as epinephrine and norepinephrine, which leads to decrease in sympathetic activities mainly on the cardiovascular system. Beta blockers are generally used in the management of hypertension, heart attacks, in ischemic heart disease such as angina pectoris and acute myocardial infarction, as well as cardiac arrhythmias. Additional uses include the treatment of glaucoma as well as prophylaxis of migraine. Practically all the applications of these agents, especially with regards to the cardiovascular disorder, are based on the fact that they act, or rather they antagonize the beta-1 receptors on the heart, which would result in decreased heart rate, decreased conduction through atrioventricular node, as well as reduced contractility. So now let's start by discussing the first generation beta blockers, which also happens to be the non-selective beta blockers, as in they antagonize the beta-1 as well as beta-2 receptors throughout the body. Examples of these agents include propranolol, pindolol, onadolol, sotalol, and timolol. Propranolol is the prototype of the beta-adrenergic receptor antagonist. So it was developed by the British scientist Sir James Black primarily for the treatment of angina pectoris more than 50 years ago. So again, propranolol is a competitive non-selective beta blocker, which means that it competes with sympathomimetic neurotransmitters such as norepinephrine for binding at the beta-1 and beta-2 adrenergic receptors. Non-selective beta blockers such as propranolol is often used in the management of hypertension. It may be used alone or it may be used in combination with other antihypertensive agents, particularly a thiazide diuretic. So the reduction in blood pressure would result from a combination of reduced cardiac output as well as inhibition of renin, all of which are effects resulting from blocking beta-1 receptor. So propranolol and other non-selective beta blocker decrease cardiac output by reducing contractility as well as heart rate, and this would then result in a decrease in arterial blood pressure. Beta blockers also have an additional benefit as treatment for hypertension in that they inhibit the release of renin by the kidney, the release of which is partly regulated by beta-1 receptors in the kidney. So decreasing circulating plasma renin leads to a decrease in angiotensin II and aldosterone, thereby enhancing renal loss of sodium and water, as well as providing an effect of vasodilation. Thus, all of this would diminish arterial pressure. Ischemic heart disease, or also called coronary heart disease or coronary artery disease, is the term given to heart problems caused by narrowed coronary arteries that supply blood to the heart. This would lead to angina pectoris, which is a sudden onset of chest pain that is felt beneath the sternum and commonly radiates down the left arm or shoulder. It can also radiate or originate in the neck or upper back as well. Angina is actually a cardinal sign of coronary artery disease, and it is caused by an imbalance of oxygen supply versus demand, resulting in myocardial ischemia and thereby the pain that you would feel. So basically, it's sort of like an alarm that alerts you that there is something wrong in your heart, and in this case, it is basically due to a decrease in oxygen supply. The effectiveness of propranolol in the management of ischemic heart disease is attributed to the fact that they block or antagonize the beta-1 receptor in the heart. So beta blockers will block the effects of circulating and neuronal catecholamines, which have the greatest effect on heart rate and ventricular contractility. So beta-1 receptor antagonism would result in a decrease in both heart rate as well as contractility, thus reducing the work of the heart and thereby decreasing myocardial oxygen demand. And in addition, beta blockers also produce a reduction in total peripheral resistance with an associated decrease in blood pressure and afterload. And these effects also contribute to the decrease in the work of the heart and myocardial oxygen demand, thus the relief of angina attack. Propranolol is used for the control of heart rate in patients with atrial flutter or atrial fibrillation. Atrial flutter is a type of atrial tachycardia that results in an arrhythmia whereupon the atria of the heart beats too quickly in a fast, usually regular rhythm. Atrial fibrillation, on the other hand, is another type of atrial tachycardia that is closely related to atrial flutter. However, the arrhythmia that occurs in atrial fibrillation is much more chaotic and results in a fast and usually very irregular heart rhythm. The antiarrhythmic properties of beta blockers are related to their ability to inhibit sympathetic influences on cardiac electrical activity. So basically, beta blockers can block the sympathetic effects and thereby decrease sinus rate, decrease conduction velocity, as well as inhibit abnormal pacemaker activity. So again, in the management of atrial arrhythmia, propranolol works by blocking the beta-1 receptors in the heart, thereby reducing sinus rate, decrease conduction velocity, as well as inhibit abnormal pacemaker activity. Another example of non-selective antagonist would be timolol. Timolol is often used in the management of glaucoma. Glaucoma is a disease that damages your eye's optic nerve. In a normal eye, a liquid called the aqueous humor is continuously produced and drained, and it provides nutrition to the eye as well as maintains the eye in a pressurized state. In glaucoma, aqueous humor builds up in front of your eye, and this increases pressure within the eye. And this increase in pressure can damage the optic nerve directly or restrict blood flow, thus damaging the optic nerve indirectly. Topically applied beta blockers such as timolol reduce the intraocular pressure by blockade of sympathetic nerve endings in the ciliary epithelium, causing a fall in aqueous humor production. Reducing the pressure in the eye would slow down optic nerve damage, which then greatly decreases the rate of vision loss, which is a worry in glaucoma. However, all that being said, let's not forget about the blockade of beta-2 receptors by these non-selective agents. And as you may recall, beta-2 receptors are predominant in lungs, so their blockade can actually lead to bronchoconstriction. Logic has long suggested that beta blockers may be problematic in people with severe asthma or chronic obstructive pulmonary disease. This was due in large part to studies from the 70s and 80s which suggested that the drugs amplify the sensitivity of lung tissues and by doing so increase the risk of bronchial spasm. Many of these claims have since been challenged, with most experts today agreeing that the benefits of beta blockers far outweigh the potential consequences. And with the development of newer cardioselective beta blockers, the risks are even less. Even so, care needs to be taken when beta blockers are used in people with severe asthma or chronic obstructive pulmonary disease to avoid potentially serious exacerbations. So with that in mind, let's move on to the second generation beta blockers, which happen to be selective for beta-1 receptors. And because of that, they are also claimed to be cardioselective beta blockers. Now, this cardioselectivity makes these agents more suitable in patients with chronic lung disease. However, keep in mind that at high enough doses, this beta-1 selectivity can be lost and beta-2 receptor blockade may occur. Examples of these agents include atenolol, acebutolol, bisoprolol, esmolol, and metoprolol. Cardioselective beta blockers have a clinical advantage in that they are 20 times more potent at blocking beta-1 receptors compared to beta-2 receptors, and this means it is less likely to cause bronchoconstriction. However, the danger of bronchoconstriction cannot be totally ignored as they are not totally selective. Aside from being associated with a lower risk of causing bronchoconstriction, the cardioselective beta antagonists are also with other advantages. For instance, they are thought to be safer in diabetics and also less liable to impair exercise capacity. Additionally, the cardioselective beta blockers are associated with lower incidence of cold hands and feet as well as having lower risk of causing dyslipidemia. Now let's take a look at this three example of beta-1 receptor antagonist or the second generation beta blocker. We have esmolol, metoprolol, and atenolol. Comparing these three beta-1 receptor antagonists, esmolol has the shortest duration of action due to the fact that it is rapidly hydrolyzed by the esterases in our red blood cells. Esmolol is given via intravenous administration for the emergency management of tachycardia, including atrial fibrillation and flutter, as well as in management of high blood pressure during surgery. Metoprolol has a half-life of about 3 to 4 hours and can be administered either via oral or parenteral administration. Metoprolol is used in the management of hypertension, angina, as well as antiarrhythmic. When we talk about the mechanism of action of these drugs, it is similar to what we have discussed previously when we talk about propranolol. Mainly, it is associated with the fact that it blocks the beta-1 receptor, especially the beta-1 receptors in the heart. Atenolol has the longest duration of action and it is considered as the most cardioselective beta-1 receptor antagonist. Atenolol has the advantage that it does not cross the blood-brain barrier, therefore the central nervous system adverse drug reactions such as hallucination or depression or even sleep disturbances are less with atenolol as compared to the other beta blockers. The clinical uses of atenolol is similar in the sense that it is used in the management of hypertension, angina pectoris, as well as acute myocardial infarction. Now let's move on to the third generation beta blockers or beta antagonists. And here you need to pay special attention because things can get a little bit tricky. Unlike the first generation beta blockers or beta antagonists that included non-selective agents, and unlike the second generation group that included selective beta 1 agents, the third generation group includes both non-selective and selective beta blockers. However, what makes the third generation of beta blockers different from the other two is that they can also act on blood vessels to cause vasodilation. So compared with classical beta blockers, vasodilating beta blockers have considerably better metabolic, hemodynamic, and side effect profile. So here we have the third generation non-selective beta-adrenergic antagonists such as carvedilol and labetalol, which produces peripheral vasodilation. So these agents, they not only block the beta receptors, but they also have the capacity for alpha-1 receptor blockade. Labetalol is a racemic mixture of two pairs of isomers that produces adrenergic receptor blockade with both selective alpha-1 and non-selective beta receptor blocking actions in a single substance. So one isomer is a potent alpha-1 blocker and another isomer is a potent non-selective beta blocker. Labetalol is mainly used in the management of hypertension or to control high blood pressure. The antagonism of alpha-1 adrenergic receptor would lead to vasodilation and thereby decreasing vascular resistance, thus contributing to the decrease in blood pressure. The antagonism of beta-1 adrenergic receptor leads to a slight decrease in heart rate. So labetalol leads to a sustained vasodilation over the long term without a significant decrease in cardiac output or stroke volume and a minimal decrease in heart rate. So the beta blocking activity actually prevents reflex tachycardia normally associated with alpha-1 receptor antagonist. Carvedilol is another example of mixed alpha-1 and non-selective beta receptor antagonist. It is actually a racemic mixture where the S enantiomer is a beta adrenoceptor blocker and the R enantiomer is both a beta and alpha-1 adrenoceptor blocker. So carvedilol's action on alpha-1 adrenergic receptor relaxes smooth muscle in the vasculature, leading to reduced peripheral vascular resistance and an overall reduction in blood pressure. Additionally, the fact that it blocks the beta-1 receptors in the heart, it would result in a decrease in heart rate as well as contractility. Mainly, carvedilol is used in the management of hypertension as well as heart failure and left ventricular dysfunction. And then we also have the third generation selective beta-1 adrenergic antagonists, for example, nebivolol and betasolol. Nebivolol is a racemic mixture of two enantiomers in equal ratios that produces both selective beta-1 blockade as well as vasodilation properties. The D-isomer is a highly selective beta-1 blocker, and actually it is the most selective beta-1 antagonist that is clinically available. The L-isomer causes the release of nitric oxide via beta-3 receptor-mediated activation of endothelial nitric oxide production, and consequently this would also lead to vasodilation, and thereby both of this together, the fact that it is a beta-1 antagonist, thereby reducing cardiac output, and the fact that it increases the production of nitric oxide, thus producing vasodilation, makes it very useful in the management of hypertension. So again, nebivolol is used in the management of hypertension, and this is due to the fact that it first blocks the beta-1 receptor, thus causing a decrease in cardiac output. Additionally, it also increases the release of nitric oxide, and nitric oxide is a trigger for vasodilation. So both of these effects altogether causes nebivolol to be really effective in the management of hypertension. Betasolol is another example of third generation beta-1 selective antagonist. It is mainly used in the management of hypertension as well as glaucoma. So how it does this? So betasolol selectively and competitively binds to the beta-1 adrenergic receptors in the heart, thereby decreasing cardiac contractility and heart rate, and this leads to a reduction in cardiac output and would contribute to the lowering of blood pressure. Betasolol is also thought to produce vasodilation by additionally blocking calcium channels. So these are the two mechanisms behind its use in the management of hypertension. It is a beta-1 receptor antagonist, thus reducing cardiac output. It also blocks the calcium channel and would thereby cause vasodilation. Both together, the decrease in cardiac output and vasodilation would result in the decrease in blood pressure, and this is the pharmacological rationale underlying its use in the management of hypertension. And just as a side note, betazolol is also used in the management of glaucoma, same as timolol. And why it is used in the management of glaucoma is due to the fact that it is able to decrease intraocular pressure when applied topically to the eye, and they do this by reducing the production of aqueous humor within the eye. So a decrease in the production of aqueous humor would result in a decrease in intraocular pressure, and thereby preventing worsening, or rather preventing the damage of optic nerve, which is what we want to target in the management of glaucoma. But the bottom line here is that vasodilation produced by the third generation beta blocker make these agents especially effective in the treatment of hypertension. Furthermore, carvedilol and nebivolol have been also shown to have antioxidant properties, which makes them beta blockers of choice for heart failure alongside commonly prescribed bisoprolol and metoprolol. Lastly, I want to briefly mention intrinsic sympathomimetic activity of a couple of beta blockers, namely pindolol and acebutolol. Now, these two beta blockers are a little special in that they have the ability to not only block, but also to weakly stimulate both beta-1 and beta-2 receptors, which leads to diminished effect on cardiac rate as well as cardiac output. This so-called intrinsic sympathomimetic activity can actually be beneficial in patients who cannot tolerate other beta blockers because of pre-existing bradycardia or heart block. Let's briefly go through the adverse effects that are associated with the use of beta-adrenergic receptor antagonists. Side effects of beta blockers on the heart and circulatory system include bradycardia, which is the slowing of heart rate, hypotension or low blood pressure, heart failure or heart block in patients with heart problems, for instance, patients with congestive heart failure, and this is due to the negative chronotropic and inotropic effects of beta blockers. Additionally, beta blockers are also associated with the occurrence of cold extremities, cold hands and feet, and this is due to reduced blood circulation. Additionally, bear in mind that abrupt withdrawal of beta blockers may worsen angina or may worsen chest pain, and it can also cause heart attacks or sudden death. So always remember that when you're trying to withdraw patients from beta blocker, it needs to be done by stages, as in you might want to reduce the dose first before you stop it completely. Beta blockers are also associated with the incidence of shortness of breath, and this is due to the fact that it causes bronchoconstriction due to antagonism of beta-2 adrenergic receptors within the airways. So beta-adrenergic receptor antagonists, especially the non-selective beta antagonists, should be used with caution in asthma patients. So asthma patients already have sensitized airways that are prone to bronchoconstriction. Consequently, if you add in a beta blocker, especially the non-selective beta blocker, it will result in antagonism of the beta-2 receptors and consequently bronchoconstriction. Central nervous system effects are also reported with the use of beta blockers, and this includes depression, sleep disturbances such as insomnia and nightmares, as well as hallucination. The use of beta blockers or beta antagonists have been associated with delayed recovery from insulin-induced hypoglycemia, as well as decreased awareness of the onset of hypoglycemic symptoms in patients with concurrent diabetes. So what you're looking at here is a diagram on the physiology of glucose counter-regulation, or rather the mechanisms that normally prevent or rapidly correct hypoglycemia. So what happens is when plasma glucose levels decline just below the physiological range, glucose counter-regulatory hormones are released, and among this, the pancreatic alpha cell glucagon, which stimulates hepatic glycogenolysis, as well as an increase in sympathetic outflow. So epinephrine and norepinephrine would also play a role in counterbalancing the fall in glucose level. They would increase glycogenolysis and glucose availability in hypoglycemia. So all of these responses mediated by norepinephrine and epinephrine would be reduced by beta-adrenergic receptor antagonists, and thereby it would delay the recovery from hypoglycemia. So beta blockers may cause hypoglycemia as well as mask the symptoms of hypoglycemia in diabetic patients. And this is because of the fact that it interferes with patients' ability to anticipate as well as counter-regulate a hypoglycemic episode. So beta blocker or beta antagonist decrease glycogenolysis and delays recovery from insulin-induced hypoglycemia as well. The use of beta blockers have also been associated with complaints such as sexual dysfunction as well as lethargy.
If you think the side effects are too many to remember, try using this acronym, BALDFISH. If you're familiar with SpongeBob SquarePants, this is of course easier to remember. So BALDFISH, BALDFISH. B stands for bronchoconstriction and bradycardia, A for arrhythmia, L for lethargy, D for disturbance in glucose metabolism, F for fatigue, I insomnia, S for sexual dysfunction, and H for hypotension. All of these are side effects associated with the use of beta blockers. So before we end the lecture, you may wonder, well, what about the beta-2 blockers? And the short answer is at this point of time, we don't have clinically useful beta blockers. And with that, I thank you for watching. I hope you liked the lectures or at least find them useful in some ways. My best wishes for your upcoming mid-semester tests.